Check one, test. Sure. Good morning, everyone. We'll start in 5 minutes time.
Recording in progress.
Good morning, everyone. Warm welcome to you on this beautiful Friday morning. And we are about to start our CME session. And I am pretty sure that you will gain a lot from this. And I would like to invite Professor Bhavanta Gamage, President of the Sri Lanka Association of Minimal Access and Digital Surgeons, to welcome you all.
Good morning to everybody. Thank you very much for spending your bank holiday or public holiday on this Friday. This is one activity that we promised at the beginning of the mid last year, that we are going to empower our young surgeons and trainees to make sure that they do their minimal access surgeries, ensuring patient safety. So we have selected three main areas to achieve our objectives. So the first session is on laparoscopic cholecystectomy, which is the commonest laparoscopic surgery that we do in this country. And we have seen the patients who are coming for this operation are young. Most of them are breadwinners of the families, and we have seen some devastating complications which will affect their entire life. So, so this session, I think all of us should have a very interactive session, and expert panel is, I don't think you can find anyone in this region better than this expert panel to discuss these topics. So I welcome all of you on behalf of Sri Lanka Association of Minimal Access and Digital Surgeons, and our association's main request is make sure that you get the maximum out of this today's program. Please ask questions, and we want this to be very interactive. So rather than spending time, I would invite Dr. Rasika Bulat-Sinhala to start the session. Over to you, Rasika.
Good morning, everyone. Thank you, Prof. Bhavanta. Please apologize for my voice because I'm just recovering from a bad flu. So the first symposium today is laparoscopic cholecystectomy. And so here we'll be talking about basically the management of complications and how to perform a safe laparoscopic cholecystectomy. So here, this is the kind of a lecture and video-based questions. So it's a good learning opportunity. You can ask questions in meanwhile. So when the session is going, so if you have any questions, any doubts, then you can ask. So here I would like to invite the panelist, the Prof. Mohan De Silva. He doesn't need any introduction to this forum, I think. He is the emeritus professor, and he was the dean to University of Sri Jayawardhanapura, where I graduated from. And he was the vice chancellor, and he was the chairman to University Grant Commission. And he pioneered hepatobiliary surgery in Sri Lanka, and he established the ERCP services in Sri Lanka. And he has trained and he has inspired most of the surgeons in Sri Lanka. And as a students, he inspired us. Actually, I took the surgical field because of you. And Dr. Tamanas Chowdhury, he obtained MBBS in 1989, and he obtained his MD surgery in Kolkata University in 1997. He has pioneered, and he is especially interested in minimal access surgery, and he has numerous publications under his name in local and international journals. And he has excelled his laparoscopic skills under Professor Palanivelu. And Dr. Vishwaras Brasu, and he's a senior consultant laparoscopic surgeon from West Bangalore, and he has obtained his MBBS in 1982 and MS surgery in Medical School Calcutta in 1992. And he has a lot of publications, especially the laparoscopic surgical ones under his name in local and international forums. Dr. V. Sudarshan is a consultant surgeon to Jaffna Teaching Hospital. He obtained his MBBS in Columbia University in 2002 and MS in 2008. And his special interest in laparoscopic surgery. So, laparoscopic cholecystectomy, which is widely been performed in all the parts of the country, and from base hospital levels upwards. So everywhere in the country, we do laparoscopic surgery, but not without complications. That is the most important thing, but not without complications. So it is very important to understand the anatomy of the region and the things to do and not to do during laparoscopic cholecystectomies and how to do a laparoscopic cholecystectomy. So the session would be, while the presentation is going on, so I'll direct some questions to the panel and then we'll have a discussion at the same time. So indications of laparoscopic cholecystectomy. So the general indications, and there are some prophylactic or relative indications. So most of the time, the symptomatic gallstones, acute cholecystitis, chronic cholecystitis, gallstone pancreatitis, the biliary dyskinesia, and the complications of acute or chronic gallbladder diseases. And sometimes it is very difficult to diagnose symptomatic gallstones from functional dyspepsia or GORD symptoms. So I would like to ask Prof. Mohan, sir, what are the tips to differentiate symptomatic gallstones from functional dyspepsia or the dyspeptic symptoms?
Thank you, Rasika, and very good morning to all of you and to my Indian colleagues. I think at the onset, I would like to say that as the patrons of this organization, myself and Dr. K.L. Fernando, I think we are so happy to see all trainees on a long weekend here. And that is the future of laparoscopic surgery in this country. So thank you very much for coming. Now the answer to the question, this is a very important question. I will just tell you only the points so that it's easy to take home. In developed countries, approximately 10% of the people have gallstones. Approximately 80% of these people have no symptoms. Only 20% approximately have symptoms. That is the second point. And gallstones and the gastroesophageal reflux disease coexist. That is also very well known. So when the patient presents to you with a epigastric pain, it's easy to exclude the inferior myocardial ischemia because of the pattern, the history, and the troponin and all that. But to differentiate between one particular, the two conditions of organ diagnosis, is this symptom, epigastric pain, arising from the gastroesophageal reflux disease junction, gastroesophageal junction, or a stone which is stuck in the spiral valve of the gallbladder, causing gallbladder to contract and cause acute biliary colic, is the point. If it is GORD, you don't need a lap chole. That is the bottom line. I would tell you how I do it, which is much easier for you to take home. I will go into the details of the history. One point which I always ask is, when the patient starts talking about the pain, patients are not surgeons, they have their own rigmarole of the story. So you guide them to find out, is this pain compatible with the biliary colic? That is what you want to know. So what I normally do is, I will ask them to tell us a story of what actually happened to you. I went home, I had a nap, I ate, I had a biryani, and after some time I got the pain. When it comes to the pain, I want to know on the pain scale, at the height of the pain, where is he going to put it, from 1 to 10? If it is 8, then my next question is, how long is that 8? Is it 1 second, or is it about 15 to 20 minutes? And what happens a few days ago? Has he had a similar attack in the past? That sounds more like a stone getting stuck in the spiral valve causing these symptoms rather than acute periodic reflux. Of course, acute periodic reflux also can mimic this type of thing. Second thing is, there is this middle group where you are still not 100% sure, where the pain is not that severe, episodic. He has had long-standing reflux, had a biryani previous day with a lot of fat, and then he had burping, and you are not sure whether that pain is there. What I normally do is, I told them I do what is called a therapeutic trial. I give 1 month. Avoid fatty food. This is only a trial. Avoid fatty foods. In Sri Lankan terms, we say when you squeeze milk from the coconut, you throw the first lot and prepare your food in the second lot. And give a course of proton pump inhibitors. Half hour to 1 hour prior to a meal, without a break, whether you have a pain or not, for one month. Primary failure to treatment for acute reflux by PPI is not common. I repeat this. Primary failure to treatment by PPI for GORD is not common. So if the patient, whilst on this regime of therapeutic trial, reporting back with another attack, then it sounds more like a biliary colic. So then 80% asymptomatic, 20% symptomatic. The probability of asymptomatic group getting into symptomatic group on available evidence, approximately 2 to 4% per annum. So it is not common, the symptomatic gallstones. So that's the way in which I handle this. Thank you.
Thank you very much, sir, for the nice explanation. So the other indication, because it's very important to understand whether we are doing a correct surgery. Because sometimes what we see is in practice, so there is a term called asymptomatic gallstones. So it is very essential to differentiate asymptomatic and symptomatic. So other indications, the relative or prophylactic indications for cholecystectomy includes the stones measuring more than 3 centimeters, and cholecystitis even without gallstones, chronic hemolytic conditions, gallbladder polyps measuring more than 1 centimeter, and suspicion of risk of malignancy like anomalous pancreatic ductal drainage, and calcification of the wall, the porcelain gallbladder, and during the bariatric surgeries, and in some ethnic groups where they have a high prevalence of gallbladder cancer, and in transplant patients and diabetes. And my next question goes to Dr. Thamunas. And the first thing is, what do you think about these size indications for performing cholecystectomy even without symptoms?
Good morning. I'm really thankful to be here from India, from AMASI, representing AMASI. Greetings from our country and our association. As we are discussing about symptomatic gallstones and asymptomatic gallstones, sir very clearly explained. But what I look, basically we the surgeons, not the person to decide to whom we operate or to whom we don't operate in asymptomatic patients. Why I am this statement? Basically, the options for laparoscopic cholecystectomy in a true asymptomatic patient should be lies on the patient. And our job of surgeon to give the all material informations to the patient and take the information. Why I am put it? So I do it in a two sides. One side, asymptomatic gallstones, some sir explained, that patient, if someone is below 50, 55 years, young patient, we expect the patient will live for another 20 years or 30 years. So there is a possibility of appearance of symptoms. And if any appearance of symptoms, if you wait for that, we all know a symptomatic gallstone with complications like either empyema or CBD stone, how much complications come up. So we miss one patient where we can do it very comfortably. So this is one aspect is there. Other aspect, if we do, what harm can do? First of all, there is a possibility of bile duct injury or complications of lap chole itself. How much complications in a gallstone disease where as such in a lap cholecystectomy, which really that should be explained that these number of complications are there, chance of bleeding, chance of duct injury, chance of these. So comparing these two, we should leave the decision to the patient himself or herself. And in our place, what we practice, welcome our President AMASI sir, Prakash and O.V. Sudhir and Partha Sarathi. Please welcome. So what I'm coming back to that, in our place, in true sense, true asymptomatic gallstone, if we talk about European, American, that is different. In books, something different. But we have seen, we are leaving patient as an asymptomatic patient. He is not doing cholecystectomy and sometime after 3 hours after patient come back with gallstone malignancy. How many patients can go for regular follow-up of doing USG in a regular follow-ups? That is also a challenge. So, considering this, and in our place, it's a very endemicity of gallstone malignancy. In true sense, if we find any gallstones, there is a lot of rules. Rule 3, more than 3 centimeter, number more than 3 stones, less than 3 millimeters. These are, and transplant patient, diabetic patient, these are controversial. But what I feel, if patient agrees for do lap chole, and if I am confident that I am a good surgeon to do it, I will do it.
Thank you. And one more question. And what about the cholecystitis without gallstones? So after ERCP, do you want to do a cholecystectomy or do you just leave the gallbladder?
If patients come with choledocholithiasis and if we do either ERCP or even any reason we remove the CBD stone, always we do the lap chole. Because more than 95% stones of CBD is a secondary stones from gallbladder. So if we keep the source of formation of stone, if we keep the gallbladder itself, then there is possibility of recurrence of CBD stone. So any situation, if not the patient is very frail or very old age, we cannot do surgery except that situation. Always in a CBD stones, if we do ERCP to removal of that stone, we always do lap chole, always do lap cholecystectomy.
Thank you. Thank you, sir. So moving on to the...
Can I just
Yes,
add
sir.
one thing? I think that's a very important question. Usually bile duct stones are secondary. It comes from the gallbladder. In my experience, I'm sure others will agree, it is more than the stone, it's the gravel and the microlithiasis and the mud. That is more dangerous than anything else because that is where risk of gallstone pancreatitis is much higher. So the patient has got, there is no bile duct dilatation, there is no choledochal cyst. Patient has got symptomatic choledocholithiasis. That patient, that means that there is abnormal bile formation, that is lithogenic bile. So there is biliary mud in the gallbladder, there is biliary sand in the gallbladder, and then eventually it comes and gets collected at the ampulla of water and get into this trouble. What I normally do in these patients, go into the history very carefully, make sure that there is no attack of pancreatitis, then of course it becomes indication straight away. If it's not there, I will speak to my radiologist and get a patient, fast him properly, and see whether you can see a layer in the gallbladder. And most of the time, a good radiologist can pick it. And I've had this so many times. And once you take the gallbladder out, everything is fine. But I think that's a very important point. Remember, more than the stones, it's the gravel and the mud that is more dangerous because they can leak.
Yes, sir. And sir, one more question I want to ask from Prof. When there are no stones on gallbladder, then the patient might claim whether it really needs to take out the gallbladder. So in that case, is there an indication for endoscopic ultrasound scan to see the biliary sludge?
Oh, by endoscopic USG, there is a biliary sludge in CBD. Is it requires any intervention on that patient?
When there are no stones in the gallbladder, only,
stones
the,
in gallbladder?
only the CBD stones.
But CBD stones is there.
Yes, the situation we talk about.
Again-
In that case, is there an indication to do endoscopic ultrasound to see whether there are microliths?
Basically, endoscopic USG we do to identify the CBD stones mostly, or any pathology around the pancreas or that region. So for gallstone identification, still now our gold standard is ultrasonography. If that does not fails, we can maximum we can go for MRCP. But endo USG only reserved for those patients for identifying of the CBD stones. But if any stones identify in CBD, there is no stones in gallbladder, we will not go for any further investigation of endo USG or something. Our strategy is very clear. What Sir also explained. We should go for that patient. If patient can tolerate lap cholecystectomy, we'll go for lap cholecystectomy. We'll not go for any more further investigations. If CBD stone identified by any means, we do ERCP to removal of the stone. The patient should be the subject of lap cholecystectomy.
Okay, thank you. So moving on to the acute cholecystitis part, again the principles of management, antibiotics, whether to start or not. Again, the analgesics, fluids, whether to keep the patient nil by mouth or whether to feed early. And then the place for cholecystectomy. So the next question goes to Dr. Bose. So what do you think, sir? Is it advisable to keep the patients nil by mouth or whether to start on early feeding after the episode of cholecystitis?
Good morning, everybody. And, I thank the AMASI senior executives and also the Sri Lankan organization senior executives for giving this opportunity. Coming to the issue, now regarding acute cholecystitis, we have to think of what is the grade or what is the status of the acute cholecystitis. If it is a mild one, yes, then the antibiotic protocol is as we do it with the normal cholecystectomy. So in induction or one more at the most.
Is antibiotic indicated at the first point even for the mild cholecystitis?
If it is an cholecystitis you are telling, and if the blood investigation show that the total count etc. are on the higher side, you can give. Because in standard cholecystitis, it is said that one dose of antibiotic is good enough, and many options are there that somebody doesn't give any antibiotics also. So I believe when you are indicating an acute cholecystitis, it is better to go with a single dose or maximum 12 hours apart, second dose for antibiotic.
Okay, thank you. And how about the feeding of the patient? I know it depends on the severity, say for a mild or a moderate attack. So feeding of the patient?
Pain?
The feeding. Start feeding.
Oh, feeding,
Foods.
sorry, yeah. Actually, in acute cholecystitis, if the patient is symptomatically improved, then we can give fat-restricted diet. It's no issue restricting the feeding.
And what is the place for hot cholecystectomy in your experience and in your views?
Yes, that depends upon what stage you are finding the patient. Say if it is within 72 hours of the onset, and if it's a mild grade, mild to moderate grade, and if the patient is not having any other comorbidities which is contraindicating to the cholecystectomy, then one should straight away go for laparoscopic cholecystectomy. And if it is severe, then initial management, conservative management to bring down with blood cultures and antibiotics, and then to rule out the associated, whether there is any cholangitis or acute pancreatitis. And if the patient improves within 7 days with a favorable symptomatic, other systematic disease comes back, improves, then also we can go within 7 days. But if it is beyond that, it is preferably to wait and go for either interval cholecystectomy after 6 weeks, or if the condition deteriorates, then we should think of drainage of some form.
Prof. Mohan, do you want to add something?
I think it's a very important, I think I 100% agree with what you said. It's a very important question for the trainees. What I normally do is, when the patient comes, get the history to find out when did that first pain episode came. That tells us very accurately the duration. That is 24 hours, 48 hours, 72 hours, 7 days, or whatever it is. You have to listen to the patient very carefully to find out how long this inflammatory process has been going on. Now, if it's up to 7 days, for experienced surgeon, you can just get away. Ideally, 48 to 72 hours, I would love to operate. It's very easy to operate with a hydrodissection. Very easy. Actually, it's easier than the conventional because the moment you put water under pressure, the whole thing dissects beautifully. But after 7 days, then it becomes rigid adhesions. Technical difficulties will come, there will be more bleeding, and especially in the callous triangle lower down, the junction between the cystic duct and the common hepatic duct, that area, it becomes fairly rigid. And especially if the stone is usually in the Hartmann's pouch, which is more on the medial side than the lateral side, where it obliterates the callous triangle and it gets stuck to the common hepatic duct. Now that's a dangerous area. Now in these patients, what I do is, if in my mind this is 7 days, I sit with the patient and with the family and explain. Your problem is a blocked gallbladder. Block is due to the stone, not the gallbladder. So we will make sure that in this operation we will release the block and you will get better. I can't tell you that I am going to remove every cell of your gallbladder either. It might be that I will go in if me and my assistant feel that it is possible to do it, but it may not be safe to do it. I will take the safety over there. Somehow I am going to do the gallbladder story, and I will tell this very accurately before the operation. Before the operation, in case of a problem, you have covered you medical legally also by explaining this by taking time, and they understand that. Thirdly, I will say, if your safety is the issue in my mind at the time of surgery, I'll be the last person in the world to go ahead. I will take the camera out, make a small cut, take your gallbladder out, maybe completely, maybe partially, but we will definitely take the stone out. If I do the gallbladder in the morning, you might be going home in the afternoon. If I do a small cut and do it, you will be staying in the hospital for another 24 hours, but you will still be going home. And that discussion becomes extremely important if you develop a complication. That's the point.
Yes,
Can I
Dr.
comment?
Manas.
Sir, is nicely explained. So always we should differentiate between a biliary colic and acute cholecystitis. Biliary colic, patient come with a colicky pain and stays for a couple of hours, then it goes down with some kind of medications. Acute cholecystitis patients, when they set in, slowly pain grows up, stays for some time, at least 1-2 days, then settle down. But what we follow, sir, maybe earlier in our, when we are junior surgeons in our PG days, or normally we say in our place, null call jol for all abdominal pain. Null means catheterization, another is Ryle's tube, and third one is IV fluid. So whatever cholecystitis patient come, we put these three and wait for some more time, 6 weeks, 4 weeks, then we operate. But I think days has changed. Laparoscopy has changed a lot. We can see the gallbladder, we can do it. So now what we follow, sir, honestly, we are not follow any number of days where patient is coming. How long these symptoms? Because there is a very thin line or vague line of the patient starts a pain, then it's a very vague. What we did, we do the USG, and our USG should be in our own person to whom we get some more information. Not the number of stones or the size of the stones is important for us. Very important is gallbladder wall thickness. Number 2, any stone stuck off in the cystic duct. If any size of stone stuck off in the cystic duct, there is a obstructed cystic duct, we always operate on that patient, except if the patient is anesthetically fit. If patient is not at all anesthetically fit, stands for GA, then we go for some drainage procedures, or else we go for lap chole. And if the gallbladder wall thickness is more than 5 millimeter, then we always hold. Even in multiple stones, we hold. We not go for surgery. Then we feel that there is something wrong in gallbladder wall, we do serial USG 2-3 times. If we check it's coming down, we operate on that situation. And definitely in between the LFT is very important, how the liver function test reports, GGT, all are acts in together. So these all combining, the number of days in symptomatic appearance is not the only issue. gallbladder wall thickness, liver function test, patient fit for anesthesia. These are all can be coming together and we can decide to whom we operate.
Thank you. This is already we have discussed. And this is the grading of the cholecystitis grading system. So the Tokyo classification we widely used depending on the clinical severity.
And one more regarding complications of cholecystitis, acute pancreatitis. So our dictum for if gallstone pancreatitis is there, I think any discussion in future or
It will be.
we have? Okay, okay. Then we discuss that.
Again, the hot versus interval laparoscopic cholecystectomy that we have already discussed, and the Prof. Mohan then nicely pointed out the very initial phases is easier to dissect because of the edema. And it becomes difficult after 72 hours because of the rigidity of the cystic and the CBD junction. And there are several accesses for laparoscopic cholecystectomy, the 3-port laparoscopic approach and the conventional 4-port approach or a single-port approach. And there are possible advantages and disadvantages of each, and then we have to talk about the safety profile of each access. And Dr. Sudarshan, what is your experience and what do you think about the 3-port surgery versus 4-port surgery, and if you have experience in single-port surgery in cholecystectomies?
Thank you, Rasika. Good morning, AMASI and SLAMADS members. I bring greetings from north of the country. So it's an important question as to how many ports you put. To be honest, I consider the safety of the operation as the utmost priority when you perform a laparoscopic cholecystectomy. The numbers are immaterial. I used to do 3-port cholecystectomies at one point, and I love to do that. But at times I got into trouble. Then I didn't stop putting more ports. Later, I thought the safety is more important. A surgeon can do operations with modifications, but when I had trainees, they look at it, and when they start with 3-port cholecystectomies. So I thought it's not nice. It's a question of the patient's safety. So I then realized I will go for 4-port cholecystectomy as conventional, and it is more safer. And that's what I continue nowadays. But more than that, now as surgeons we have sometimes fixed ideas, like laparoscopic cholecystectomy, we put 4 ports. No, you may have times, complications where you may have to put additional ports, 5th port, 6th port. It depends on the safety of the operations. That's what my opinion is.
I like to
Yes,
say
please.
something. I have reservation for 3 ports for very obvious reason that when we talk about safe lap chole, we talk about establishing CVS. And to establish CVS, you need to open up the callus triangle. And for that, you need a fundal traction toward the right shoulder of the patient and a Hartmann's pouch traction toward the right hip of the patient. Now, with a 3-port, you cannot have that fundal traction. So, ideal opening up of the callus triangle for its safe dissection is compromised. And that is one of the major reservations for me for going for a 3-port.
Okay, thank you. And
What we can do, we cannot reduce the number of ports, but we can reduce the size of the ports. Instead of putting 2 10 millimeter, 2 5 millimeter standard ports, we can replace the 2 5 millimeter ports if we really do by mini ports. We can do epigastric as a 5 millimeter port. Even paraumbilical port can be a 5 millimeter. With the 5 millimeter telescopes, we have a very good telescopes. If we have a endoclips, 5 millimeter endoclips, if we could do, so that we can reduce the size of the port if you really want to, but number of ports should not be reduced, it should be 4. Yes, sir.
Yes, sir.
Just one thing I like to add regarding the 3 ports. In reality, I do make 4 ports, but it seems to be 3 ports because I make a routinely 5 mm telescopic port through the cicatrix of the umbilicus. So ultimately, that port is invisible. So all 3 ports even, but you cannot compromise with the number of ports.
Yes, yes, Prof. Mohan.
I think for the trainees, I want to tell you one thing. These are just a small technical point. It's the tricks of the trade. When you hold the gallbladder fundus and push it upwards, remember in your mind that you're closing your callous triangle. That's the first point to remember. Without realizing, you're closing the callous triangle. When you get the Hartmann's pouch laterally and retract the gallbladder laterally, you're opening the callous triangle. So actually your dissection is in between these two. One closing the callous triangle, other one is opening the callous triangle. So when I started my first exposure in London with John Cochrane, who was a top-class left-handed surgeon, he was doing the 3 ports. I am also left-handed, so I also learned the 3 ports. But later I realized that once you open the callous triangle with the left hand, while holding the callous triangle laterally, it is much easier to dissect it nicely, rather than doing all at the same time. So after the first 10 or 15, I converted myself to what is comfortable to you. My advice to you is, you try both. You make sure that you will continue with what is comfortable to you, which is the technique which is safest for your patient. Don't be dogmatic. I 100% agree with you. You don't have to be dogmatic. You try it. It's how safe and how comfortable you during the time of surgery with your own hands. And that is what the number should be.
Thank you, sir. And the port placement that we have already discussed, the 4 port, and it seems that since we are obliterating the callous triangle with our fundal retraction, it is essential to establish another port for the gallbladder retraction downwards. Otherwise, we are closing the callous triangle and leading to unnecessary complications. And again, I would like to ask Prof. Mohan regarding the port placements. So what is the first port and the second port? Why whether the second port should go to the epigastrium or the lateral port? So what is your preference and how do you advise us?
Interesting. I get into the infraumbilical 10 millimeter port to put the camera first. And I was used I was trained and I went on doing the open technique, so I don't change that concept. My colleagues like Bhavanta and Sanjeev does it through the umbilicus in a different technique, but I continue to do my technique which I have used to. Once I get the view, then what I normally do is I lift the head and turn the patient to the left. Then the liver will fall back and the small bowel will also fall back. Then I put the most lateral port, that is anterior axial line or most lateral port depending on where the position of the gallbladder is, and hold the fundus and push it down, push it upwards. So the weight, the position will pull the liver down and the traction will push the liver up. That is where I stand at the moment. If the stomach is distended, my friendly anesthetist will put the NG tube and suck it, but I don't routinely tell them to put the NG tube because as a patient, I myself would not like to have endoscope, the endotracheal tube. So if the stomach is distended, I tell him or her, otherwise no tube, not a routine thing. Once you do that, and then next one is my epigastric port. Now epigastric port, what I normally do is I press and just to the right of the ligament and almost at the edge of the liver, that is the position in my mind. And then I position it and make sure that it's not going oblique, but it's going straight. And once I do that, then I pull the small bowel down and to the left, and then you get a good view of what you're going to do. And then only, final port is my left hand dissecting port. I'm a dominant left hander, so that's important for me. So because my dissection is going to be in the right hand. Now, however experienced you are, I'm sure all of you will agree, depending on the body stature and the costal margin of the patient, either you might be going too close to the costal margin and you start fighting with the rib, or you go too down and you be operating further down. So before you put that final port, you just position yourself. Even at my stage, I still do this. See how comfortable I am, and that is the point I am going to put my last port. That's what I normally do. So that dissection will be not like this or not like this.
I like to
Yes, of
add a
course.
few things. Regarding the port position, one has to keep in mind the ergonomics also, because that influences the port position. This is not fixed port positions you do here, and what he said, I agree. But it is on the height of the surgeon, or what is the flexibility of the operation table at government hospital. Always you won't find a friendly table for you. So this is also important. And another important thing is, after doing the optical port, it is better to put the patient in the position you want to operate before going for the epigastric port. Because if it is a high BMI patient, it's a fatty liver, so you might think of an epigastric port at a point where it might be difficult for you to retract the liver, or you might be too low. So these things needs to be adjusted. There is no fixed rule that you make this port over
Yes.
here, that port over here.
Yes, thank you. And now already we have discussed this part. This is a video running the port insertion. So panelists can comment on the technique if possible.
We are not following Mohan sir's principle here.
Yes, sir.
Yes. What Professor Mohan told about port placements, it's a true if we do like that, but honestly, really we do it? I don't know how many of us is follow these principles. We put peri-umbilical, I say not always either infra, sometimes we go supra if the patient is tall, from the xiphisterna, if his length is more than 15 centimeter, we go slightly higher up the epigastric port for visual port. As we follow always by very close technique, so we go supraumbilical, then followed by epigastric. Age of the liver is very important. Slightly we assume that if we retract, liver will go slightly up. So we take slightly upper part of the age of the liver. Then we follow, basically sir told very nicely, that should be the principle of placement of ports. That we should accept.
And for the trainee's point of view, the first port is we are putting, and if there is something or damage or complication occurs with that, that is considered as an accident. When you put the subsequent ports, you must always visualize it and put it. But if you don't visualize and you get into trouble, it is considered as a crime.
I can tell you one interesting experience. In late 1990s in UK, my friend, who was a Sri Lankan, was doing the lab cholecystectomy. I was assisting him. He has just had the training. Those days, a Verus needle concept. So, Sela put the Verus needle, and it was not going. And he tried again, and he tried again. That's the whole good word. But the visualization was not very good. And then, pressure is not coming in the right way. The last time he put, I didn't like the way it happened. When he pulled the thing, I said, give the Verus needle to me, and I smelled it. And there was a fecal smell. And we did a laparotomy, there was one hole in the transverse colon.
I think most difficult step in laparoscopy learning is putting the fast rocker. Either by open technique or varies, followed by fast rocker is the biggest challenge in laparoscopic surgeon's life. Same thing happened. I just tell one other story. We are doing one bariatric surgery. Patient had almost 42 BMI, and the patient is one limb amputee. So far I remember, a left limb amputee. Lady had an amputation of left limb. Then we are putting the varies in supraumbilical. Somehow we are not happy with that. We tried twice, thrice. We are not happy. Then we tried in Palmer's point. to put the varies. We tried twice, we are not that very happy. Then slightly we feel some insufflation. We put a 5 millimeter trocar at the Palmer's point and we put a 5 millimeter telescopes. We go inside and we see there is a huge adhesions and we are inside a lumen of a bowel in that patient. Then subsequently, naturally, we opened up and we cannot identify the limbs of the loops, where it bowel is coming from which end and how it. Then somehow we managed to identify the injury of that trocar entry. Then we identified that part we repaired and we put a drain, come out. Patient developed a fistula from that incision. Patient lost a body weight almost 20 kilos in next 3 months. Bariatric surgery is already done, and then we think for other surgery in that patient.
About the additions, I will tell you one experience.
And why it happened? The key point of these patient have a amputation because of filariasis, and maybe that patient have a chylous peritonitis, and that leads to this amount of adhesion without any previous history of surgery. These patients have these kind of adhesions, and we miss that part. The patient has an amputation for a filariasis, and that leads to chylous peritonitis, which adhesions. That is the key point to.
One fine day you will find what adhesions are. There is a subgroup of patients with what are called cartilaginous adhesions. I have seen only once. Bhavant assisted me, young man of 23, a medical student, who's had a laparotomy for hemoperitoneum years ago in Dubai, came with a severe adhesions and intestinal obstruction. He will tell you, from 7 p.m. till 2 a.m. in the morning, both of us were not sure what we are dealing in one segment, whether it's a large bowel or a small bowel. You won't believe it. Actually, this, ask him, till 2 a.m. we are not sure whether it's a tinea coli or whether it's a distended small bowel. Because adhesions can be, I'm sure all the experienced surgeons will tell you one day, this so-called adhesions which is in the textbook is nice, but one day, 1 in a million, you will get it this. So you have to be very careful.
I like to tell to the younger surgeons that for the safety, if you put your index finger at the level of the point of the either trocar or of the varis up to which you are intending to introduce it, and try to push your right shoulder and the elbow backwards while you are rotating and pushing it, so that when the resistance is gone, inadvertently it will not enter, because you are having one is push of this one backwards and one the finger. So that also helps in avoiding injury in the abdomen during the first entry, because with varis you are having 2 chances. One is with the varis and with the first port.
We will not debate about the access, varies or open or trocar. Okay.
Okay. So the gallbladder retraction, sometimes we find difficulties in retracting the gallbladder. So without adequate retraction, it is difficult to perform the gallbladder. And when the gallbladder is grossly distended, and there are several techniques that we can do to overcome this situation. And Dr. Thamunas, what are the techniques you would do? What would you do in cases of difficult retraction?
Traction can be difficult because of reason for gallbladder itself, because of liver, and because of body structures. So if the patient structure we cannot modify, the gallbladder, if the reason for gallbladder, sometimes if it's a empyema or mucosal, it's a very hard to hold, thickened gallbladder. In that patient, we can drain the gallbladder, aspirate, and then we can retract. But if the patient has a mild cirrhotic or heavy liver, particularly in obese, then the challenge is very big. So in that case, we have to be very gentle. And sometimes we may hold the body of the gallbladder and we retract slightly upwards, means towards vertically we can put a traction so that we can open up the callots. Another issue, what we do regularly, if we find any, when we retract the gallbladder, if any difficulty because of some adhesions of the liver within the some duodenum and others, that we dissect slowly, then we start retracting. Others is sometimes, rather in our almost 30-40% patient, we cut the falciform ligament. Probably have seen when we retract gallbladder, we cannot retract properly, and there is a number of times injury at the junction of the falciform ligament and liver. And that really, and if we start by forcing the retraction and we start the procedures when the instrument goes in out, inadvertently there is injury. So we cut the falciform ligament. Earlier, very 10-15 years back, after surgery, we repaired that falciform, but we have seen nothing happens. Now, routinely, most of the time, any difficulty in retraction, we cut the falciform. Any difficulty for gallbladder itself, we aspirate. If a thin gallbladder, instead of gallbladder holding forceps, we go for a tooth forceps with a heavy grasper. We hold and we retract. Until unless we have a good retraction, we cannot do a good lap-colli.
I'll run this video. And what do you use for gallbladder aspiration? Is it just the aspiration needle or the trocar? What do you use?
We use, we have a aspirator that first time, or sometimes we put the directly 5 millimeter trocar inside, and through that trocar we aspirate.
Okay. Thank you, sir. And we'll just go through the video.
At times, you can, if it's a contracted gallbladder, difficult to hold, you can put a stitch at the fundus and also put a traction through the skin. And opening the fronts of the, in a left-hand instrument, if you push the gallbladder, you can have a retraction. So these are all things you can think
And
of.
if retraction is not proper, sometimes we put one more trocar and we just put down the duodenum and other colons below, so that you can open up that surgical areas properly. That's a other way. If we cannot go up, we go down.
So due to time constraints, then I'll try to reduce some, cut down some videos. This is another video. So the distended gallbladder, very angry looking. Thank you, Dr. Sudarshan, for your videos. And Dr. Sudarshan, you generally hold from that hole and then you do the rest of the dissection, is it?
Yeah, that's what I usually do. But in case if I happen to, I can't hold it, I will put a stitch and close it.
Can I just add something?
While aspirating, instead of aspirating the whole gallbladder, if partial is done, then the contour of the gallbladder is maintained, so it is very easy to identify the calores, I think.
I was just
Yes,
about
sir.
to say the same thing in a different way. When the gallbladder is distended and doesn't look that angry, I think having a normal anatomy is easier than sucking and getting abnormal anatomy, because remember that when you pull the Hartmann's mouth laterally, if the bile duct is small diameter, you are tenting the bile duct. So that risk is higher when the anatomy is distorted once you aspirate the gallbladder. That is my personal experience.
So if we cannot retract, then only we aspirate. If we can
Yes.
retract it, we go with that.
It depends
To
on the
maintain the
situation.
anatomy.
Yes,
Yes,
yeah.
yes, yes.
Okay. So the dissection of the callus triangle, or the hepatocystic triangle. So the callus initially described as the anatomical space bounded by the common hepatic, the cystic duct and the cystic artery. Then later on it was revised as the inferior border of the liver in the superior border. And then the newer concept came like a hepatocystic triangle rather than the callus triangle. So, Dr. Basu, and what do you think? Is it same or different, whether it's the callus dissection or the hepatocystic dissection, and what is your opinion?
Actually, whatever term you use, it is essentially the hepatocystic triangle dissection which is important.
Yes. And what are the things then we always talk about the critical view of safety and that adhere to the safety rules. And do you want to elaborate something on critical view of safety?
Yeah, we all know about the three components of the critical view of safety. The fat and all fascia should be cleared of the triangle, and the gallbladder should be dissected 1/3 of from the infundibulum, from the hepatocystic plate, and two and only two tubular structures entering the gallbladder. So to achieve that, the retractions we talked about earlier will open up it, and then we should follow few rules that we should start the dissection above the rubeus sulcus. Now, rubeus sulcus has a difference. At times it is absent, at times it is very thin, at times it is having two lips. One should remember, if it is having two lips, it is the upper lip which should be taken as the level, not the lower lip. And when it is absent, then we have to think about the limb node of Lund, that we should not go beyond that, or the D line, we say, of the segment 4, the dorsal end of the right side and the ventral end of the left side. If you draw a line, that is always above the rubeus sulcus. So these are the things we have to think of, the level of dissection to start with. Okay. And then you have to start.
Okay. Dr. Sudarshan, you want to add anything more? And for the trainees, the importance of critical view of safety?
For the trainees' point of view, the identification of critical view of safety has made this operation very safe. And globally, the evidence says the bile duct injuries rate is coming down. And the other important thing is it's becoming a legal component in your operative notes to document that you have achieved critical view of safety. And it's always important to start the dissection from the part of the gallbladder and coming towards the cystic duct.
Yeah, I think in this discussion, this is the most important part of the discussion in my mind. The point is that when we were surgeons who got into laparoscopic surgery after a long period of open surgery, I'm sure most of us are here, when we started learning the open surgery, open gallbladder surgery, we were taught to look at the junction between the cystic duct and the bile duct. When the laparoscopic cholecystectomy came in, the interest went into a different junction, that is the infundibulocystic duct junction, not the junction between the cystic duct and the bile duct. Therefore, when you try to define the infundibulocystic duct junction, you get the superior point, inferior point, then you get the circumferential control. Now, that's not the end of the world. That is the main point. Because there is this segment of tissue in that triangle that is between the common hepatic duct and the cystic duct, and that area, thick tissue, in those patients which are challenging ones, thick tissue. Now, there my practice is, at that particular situation, I think if it's my sister, what I'm going to do, I will, in my practice, this is not a rule to remember, this is my rule to myself, I will not put a clip and make a decision to divide that duct which I have interpreted as a cystic duct till I demonstrate at least 1/3 of the superomedial wall of the gallbladder from the junction which I have interpreted as the infundibulocystic duct junction. Even at this stage, I have had several situations where that answer to that question is not clear, I open. I'm sure a lot of laparoscopic surgeons won't do it, but that is what my practice is, because I've never gone wrong so far with this technique in my period of practice, because you don't take a chance with it. Because well-known fact is that so-called classical, what's called the classical injury for bile duct is the tenting of the small bile duct. When you see a white cystic duct, you think it is a bile duct until you prove that it's not the bile duct. And the way to prove is from the infundibulocystic junction, not the lateral side. Medial 1/3 should be demonstrated, the gallbladder wall should be demonstrated. Then and then only you decide that this is the junction, infundibulocystic duct junction, this is this white cystic duct is actually the white cystic duct and not the narrow bile duct. Then and then only you divide. Once you divide, point of no return is achieved. That is my practice. Safety is number one, and I 100% agree with Sudarshan. medical legally, it is very difficult to get out, at least in Sri Lanka. For the moment, if you transect a bile duct, it's very difficult. So don't get into that mess.
Thank you for sharing your experience with us. And this is the universally accepted protocols for safe laparoscopic cholecystectomy. This is the SAGES protocols. So the most of the parts we have already discussed, the critical view of safety and identification of the cystic duct and the cystic artery, and that the Prof mentioned, and we have to clear the proximal 1/3 of the gallbladder and the cystic duct and the artery before doing any irreversible steps. Then we should demonstrate there are only two structures hanging the gallbladder, anteriorly and posteriorly. That is need to adhere to the critical view of safety. As Dr. Sudarshan mentioned, it's a legal requirement in most of the countries, and in coming years there will be a lot of litigation in our country as well. So it is important to adhere to the protocol. Then we are legally protected at least. And the second step is we need to understand the potential for aberrant anatomy in all cases. And then think about the short cystic duct, sometimes the aberrant hepatic arteries, and then sometimes the right hepatic artery that crosses anterior to the common bile duct. So we need to always think about, could it be something different or could it be aberrant one? Then we have to be vigilant.
Actually, to avoid those type of injuries, one should be very, very close to the gallbladder wall while dissecting in the CVS. On lighter side, I tell my juniors, think gallbladder as your fiance, not as your wife. So you will be closer to the gallbladder.
So the third step is make liberal use of intraoperative cholangiography during surgery. So, Prof. Mohan, and what is your experience and what do you think the role of the intraoperative cholangiogram in cholecystectomy? Is it to be routinely used on, or is it to be used selectively?
I think what's happening in the world is that depending on the unit you work, you got a unit type of protocol where there are some units. Now, people who are training cholecystitis, I know that everyone gets a intraoperative cholangiogram. I think in our setup, what actually happened, and also it happens in most of the centers in England as well, that when you're comfortable with one system and chance of bile duct stones are less, you don't normally do an intraoperative cholangiogram. In my unit, in our unit in Colombo South, we never had that problem because we had a lot of expertise in ERCP there. Our access was 100% for the ERCP, so people who have worked in our unit, that was never a problem for us because we were not very, very, very comfortable with the bile duct. But in general, what I thought, it's my personal feeling. If there is a doubt about the anatomy, one way out is to start doing a retrograde dissection so that you can see the gallbladder. If you look at this area, this is not normal, this is different. Then in that case, you can dissect it from upwards. Then the anatomy becomes clear. Don't put any clips anywhere till the anatomy is 100% clear for you. I think that is the way. Of course, at that stage, you can decide, you can inject the dye into the gallbladder. Rather than trying to get into the cystic duct, you can inject the dye into the gallbladder and see where it's going. That's not a problem. That's in actually real practical situation, that is what I would do. But I think it depends on your unit, and some people have got set up nicely, you have the catheters nicely, and by all means, I think you should do that in that way. Yeah.
Thank you, sir.
Instead of now, earlier we do sometimes IOC, but now I think we are using mostly fluorescence cholangiography. We are using in routine, almost in 100% patients we do fluorescence cholangiography. I mean, at the time of surgery, we change the mode and we see where it's bile duct. If any doubt, that really gives a very good guideline.
So how about the cost of the fluorescent dye?
Fluorescent dye is approximately 2,000 rupees. 6 patients. Around 200 to 300 rupees per person, per patient.
Okay.
But the camera system should be upgraded. that should have a infrared reading capacity.
Okay.
I also agree with that, that ICG is a better option. But if you don't have it, I have reservation for IOC. Because in IOC, you need to identify the cystic duct to cannulate. And if I can identify the cystic duct for cannulation, why I need it? I have question in myself. So in that case, if ICG is not available, I'll go for a subtotal.
Okay, thank you.
The point is that actually, in practical point, if you can easily cannulate the cystic duct, actually there is no need for a IOC.
No, sir, earlier indications for IOC was that we have a suspicion of bile duct injury. In spite of we have identified the cystic duct, in spite of anatomy is clear, but there is some lateral injury or there is some bile, golden bile is coming, and we are not very sure from which source it's coming. To identify that area, we do the IOC and earlier part. That is the, I think still that indication is persists. It is a smaller duct, how much diameter of that duct, to identify those things, we can do IOC on that situations.
Okay, and this is the fourth step in SAGE's the protocol, the perform an intraoperative timeout. There's a kind of a pause before clipping the important structures in the Callas triangle or the area. And Dr. Bose, what do you think about the intraoperative timeout?
Always, Dr. Bose?
Do you always, yes.
Yeah, this is very, very important. For all laparoscopic surgeon doing gallbladder or any surgery, at times you zoom out. Any process you do, you zoom out. So you see where you are rather than focusing in one point. And particularly the difficult gallbladder, that is very important. And that is a part of the timeout to see what are the adjacent structures available over there, the be safe we call it. Whether we are away from some important structure or close to it. These are all important things, and you can have an idea also from the camera person who also happens to be a surgeon. So that be safe is very important where you are. So that is of utmost importance in timeout, and that is also applicable for applying clips. When you come,
yes,
it is also
important. So this is the next step is the...
Can I comment one? Regarding basically timeout, it's a question of the surgeon's, what I say, psyche. Timeout, pre-operative timeout, in most of the theaters, I think follow the pre-operative for surgeons, for anesthetists, for team members. Power-operative timeout is a surgeons must be very careful about it. Basically, we learned this timeout from the aviation industries. The pilot must announce that I am in this situation, I am in this condition. He must louder say. And why not my assistant who is doing, even if he's a junior, he can listen and he can respond to that. I think that's a teamwork. It's not the surgeon himself only doing the surgery. It's a teamwork. So there is no harm. Surgeon should announce before clipping that I am going to clip the cystic duct. Is it cystic duct? Everybody okay? Then we can clip it. It's just a few seconds. But it is the psyche of the surgeon, and we follow always. At least whoever is assisting, we discuss. Means before clip, we say it is a cystic duct, I am going to clip. Is okay? Then we clip it.
It's very important to keep the operating theatre calm. Then sometimes the operating theatre environment is, nasty, and the surgeon is hot-tempered. Then the others will not tell anything. Okay, you cut the cystic duct.
Very correct, very correct, very correct. And they are discussing about some movies,
boss
some
is always correct.
distractions.
Okay, thank
That
you.
must be avoided.
So moving on to the clipping techniques, and Dr. Tamonas, do you use, how many clips you use, and what type of clips do you use? And do you use clipping and combination of suturing?
Mostly we go for LT300, and the company prepared for us 6 clips. So we use 6 clips. 2 for cystic duct, proximal, 1 distal, and in between cut. For artery same, 3 clips. Now question is, in a box you have a 6 clips, and if the 6 clips is exhausted, then how many clips we can ask for? We should, if the more clips is required, mean we are in something different. A maximum 1 more clip required for sometimes posterior cystic artery. Rather, and apart from LT300 clips, we never use LT400 clips. Never. If we require really, it's a slightly bigger diameter for cystic duct clipping, we go for hemoclips. One hemoclips, and other side we put LT400, not in proximal side. And if that is not, we feel not sufficient and we are sure it's a cystic duct, we can put an endoloop. After dividing the cystic duct, we can put endoloop. But regarding clips, standard, we follow 2 proximal and 1 distal clips.
Okay. So 2 proximal clips and then 1 distal and divide in between.
Can I just add something?
Yes, sir.
The taking on from what Sudarshan said, the when you define this duct, which in your mind is a cystic duct, there is a thing called cognitive illusion. That is, you have come to a conclusion. This is cystic duct. And the one thing you should never do is that once you get your Maryland forceps at the infundibulous cystic junction from the callous triangle to the other side and open up a little bit and you create a space, that is the time you must never ever put a clip. Never. Despite telling this to so many people, I still see surgeons get a huge happiness once you get this space between the infundibulous cystic junction anteriorly and the posteriorly. Now you open it up a bit, now there is a duct. Now there is some people have a compulsion to put the clip there. Now you must never, as a trainee or a senior surgeon, never ever do this. Because your cognitive illusion might be wrong. It might be a narrow cystic duct. It might be a narrow bile duct. Because you have been and be aware of easy gallbladders. Easy flexible gallbladders. You just put it, your mindset, you know that it's an easy one. Lift it on, divide. And you've been pulling the thing. And a small diameter bile duct, you have narrowed it down, you have dissected it down. And classic injury is that. So be aware of easy gallbladders.
I like to add one thing with this picture.
That
If it is an easy gallbladder, as sir said, and if it is an old age patient with less tissue strength, and the still picture you have shown, if that is the position you are trying to apply the clip, you are doing 2 wrong things. One is you are pulling the callus so that there might be a tenting, and you are putting the clip like that, this so that it might take a part of the wall of the CBD. So it is always better to have a perpendicular position with a loose hand, left hand, so that there is no tenting and it does not take a part of the CBD. That is very important.
Let's see.
We'll go through the video and you can comment on the clipping.
No.
So you can see the both sides.
No.
So I'll stop the video here. And Prof. What do you think about before clipping the cystic duct? Do we need to sweep whatever the things inside the cystic duct towards the gallbladder, or just clip it?
I will drop that Hartmann-Snow's retraction off and see where it stands first. That's the first thing I would do.
Yes.
To make sure that you are not tenting too much. And after that, I will just using a Maryland and just gently compress that what is like a bulge, whether it's a stone or whatever it is, and see whether I can milk it out. Because I think your spiral value is just above that actually, most likely.
Yes.
So I will be very wary of that, what is dilated there. before I do
Yeah, exactly. The cystic duct dilated, that part may have some stones.
Stones inside.
Maybe.
Or maybe bile duct on the other side, turning that way, because you're pulling it.
So, in these situations, we must be, even in these situations, we are not very sure about any remnant stone or something. Sure. We open up the cystic duct partially. We milking the cystic duct. We check something is coming out. We can see what is there. Then we can clip it.
Thank you. There's one more video. I'll stop here because we can't see the both sides here. And so do you have any message to trainees regarding the clipping here? Because we can't see both sides, but we do clipping sometimes. Is it safe or should we do that?
Surgeon is doing flag movement after clipping. Rather than putting the clips, fired the clips, he must do the flag movement before that. putting the clip plier on there and check from both sides, then it can be clipped. That is better options than clipping and then do the flag movement.
I will also lift the left lobe a little bit before putting clips and see whether I can see the common hepatic duct above.
Yes. And here
I'm
we
sure you've done it, actually.
clip the cystic duct first and then the cystic artery. Any comments?
I think that hardly matters, but always we follow if cystic artery is dissected, we always clip the cystic artery.
Then we have more freedom
Because
to.
that is a weaker structure compared to duct. Risk of tearing of artery is higher. So we always.
Here you can see the proximal clip is almost flush placed with the CBD. And I think this pulling of the left hand is very important. It should be relaxed.
Yes, left hand.
At the time of.
See?
You can
Okay.
tilt it.
Thank you. So because of the time, then I will move to this. This is the retrieval of the gallbladder. And Dr. Sudarshan, what is your experience in retrieving gallbladder? Do you regularly use endobags or do you have any other techniques
No,
or
we-
locally modified ones?
We don't regularly use endobags. One reason is it's not freely available in the government sector. The other reason is some of the gallbladders which we do for a routine case which are not infected can be easily taken out through the umbilical port. The problem comes when the gallbladder is infected, inflamed, and there is pus or when there is some leakage during the dissection from the gallbladder side, then you need a retrieval bag. So the prices of the retrieval bags have gone up to from 5,000 to 25,000 in recent years. So that add to the cost. So we try to modify it. Either a Riles tube bag or a catheter bag can be taken. Now very recently we had problem. These Riles tube bags come as biodegradable, and when you pull it, it tears off. Now what we use is the glove. What we can do is we can cut the finger side of the glove out and use the cuff. And you can tie it the distal end and invert it. So it becomes a bag and it's very flexible, stretchable and strong enough. So you can use it instead.
And
And we always use endobag.
you use?
Yes.
Routinely.
Always.
And
Routinely
always
use.
gloves. And
Gloves,
also you
only
cut
hand
the
gloves.
rim also. If you cut the rim and then you tie and cut the fingers,
Okay.
it's a very good bag.
Okay. Thank you for the tips. And this is a step 5 in the difficult cholecystectomy. Then most of the things that we have already discussed. And so when we are dealing with a difficult gallbladder, and is there any way to predict that it's going to be a difficult gallbladder? Prof. Mohan?
I think it's a individual thing depending on your experience also. I think what is difficult for me might be not difficult to some very experienced surgeons. But I think it's more than difficulty or non-difficulty, it's a safety that matters in your mind. If in my mind I think it's not safe, then I will do the plan B actually. That's what I normally do.
Apparently, when you enter, if you find that the gallbladder is buried within the liver of 50% or more, or there is adhesion up to the fundus, then you can assess that this gallbladder might be difficult. But if it is a floppy, it may not be.
Basically, difficult gallbladder can be for a person, difficult gallbladder for the other person may not be. But as a surgeon, for me, I always consider all gallbladders are difficult before re-entering theatre, number one. But some of our team members assess how we can predict that this patient will be difficult. If have a repeated attacks of cholecystitis, if the patient is obese, if the patient have a history of cholangitis, those patients and the thickness of the gallbladder, size of the gallbladder, if it is very small, post ERCP, post pancreatitis, those patients we can predict that these gallbladder will be slightly bad. But Yeah. So if the patient have some, some other surgeries, so access will be difficult. So access difficulty, dissection difficulty, retraction difficulty, these are in all levels we can assess some amount. But truly, until unless they come out smoothly, the gallbladder is difficult for every surgeon's life.
That's a good messaging. Yeah.
That's why our one of our team members, senior team member, he's very religious person. So he put a writing before the entering in theater that karmanne madhikarastu ma phalishu kadachana. Because you are entering somewhere, you do your work, don't think about what the result. Always we look in that word and we enter in the theater. Like in probably you have seen in the windows of the doors of the Indigo flights, you are entering in a place which is very, very high risk zone, meaning in cockpit.
Okay, thank you. And if you can't achieve the critical safety, then you have to think about the bailout techniques like subtotal cholecystectomy or a cholecystostomy, or just a tube drainage, or just to wash out and take the gallstones out and leave the gallbladder stump. So, first of all, the bailout technique. So, when you are bailing out, so should we feel inferior or should we feel guilty about it, Dr. Kamanas?
Never I feel inferior if I do some bailout procedures. Rather, I feel I am lucky. I am happy today because I can come out without injuring bile duct, without doing much more complications on the patient. I can bail out from the situations. So that is first feeling. Never I feel inferior. Rather, I have seen people who feel that conversion or some bailout like a subtotal cholecystectomy, they forcefully try to do. Ultimately, they make his own life miserable and the patient's life for biliary cripple for rest of life. So at least what I feel that bailout procedures, the term is very clear. Bailout is for the surgeon and for the patient and for the institution itself. We never feel guilty or inferior by doing a bailout procedures.
That's a very important message again.
I think I just want to tell you that if you have a doubt, it is always safe for the patient for you to have a bailout procedure, but much more than to your patient, it is the safest for you. That's so remember, it's the safest for you.
Even we putting the fast telescopes or one port, we come out and we'll keep the patients for another 6 weeks, 8 weeks, and we do the lap chole. Even that we have done, and at least one or twice in a year we did it.
Exactly. The junior surgeons should remember the basic laparoscopic procedure is lap cholecystectomy. But any complications arising from them are all advanced. So please remember that and keep it in mind.
Thank you, sir. This is a step 6 of the SAGES, the get help on difficult cases. If you are in difficulty, don't hesitate to ask help from a colleague surgeon. It's very important. If you are unable to achieve the critical view and if the anatomy is unclear and the surgery is not progressing, then stop and seek help. And then we have to take advice on when to convert. Prof. Mohan, do you want to add something? When to convert and when to take that decision?
You convert when you are happy, when you are not happy. That's it. For the trainees, if you are going to have today 2 lap choles and tomorrow the next lap chole, all 3 you have to convert. Never feel guilty.
Thank you, sir. And sir, have you had this experience missing gallbladders or absent gallbladders? Have you experienced this situation before? Do you have any experience?
Yeah, once actually. Actually, it was during the open cholecystectomy. And that patient was a bit of a high flyer also. I went in and struggled and struggled and struggled. And eventually I found that it's a thinnish gallbladder deeply embedded inside the liver in the middle of adhesions. That's during the open era, but not laparoscopic era.
Okay.
But it took about 3 hours and I was not trained to retract also.
I have a publication on agenesis of gallbladder. I have found 3 cases of agenesis in where 2 cases were operated And that is why the publication was made, how the absent gallbladder was missed by the ultrasonography. And the explanation in the literature is the gallbladder fossa is occupied by fats and food particles of the duodenum. That gives a misconception of gallbladder, and we had to do it, and ultimately no gallbladder was found. And subsequent MRCP also didn't show any intrahepatic gallbladder also.
So the movement of complications, the surgical complications we talk about, and the bleeding during laparoscopic cholecystectomy, and the bile leak and the visceral damage. Those are the things that can happen. So during intraoperative bleeding, Dr. Bose, what are the tips as a surgeon, and how should we handle the situation when we encounter with a bleeder?
If there is bleeding, two things are very important. One is you put a pressure with a gauge piece at the point of bleeding, and the surgeon should remain calm and patient, so that every 30 seconds he should not remove the pack and see whether the bleeding has stopped. He should wait for 5 to 8 minutes or 10 minutes. And nearly 80% of the bleeding stops. And at the same time, he should ensure from the anesthetist that the patient is not in a hypotensive state. So there should not be a false belief that it has stopped. But mostly it stops. If it doesn't, then you have to put some stitches, but never give cautery. Electrosurgical devices should be avoided.
We should be prepared that during lap chole there is a possibility of bleeding. So how we get prepared? We always put a piece of gauze at the beginning of the procedures. The moment we put the epigastric trocar, we take a piece of gauze inside. Always we keep it. The moment there is any bleed, immediately give a pressure. That is the first step we do. Then we identify from which level. It is when at the time of cystic duct dissections, at the time of liver bed dissections, in which time we are getting bleeding. According to that we act. But we always keep a piece of gauze, and that to be give immediately compressions.
Even the gallbladder itself is a good gauge piece. You can put the pressure with the gallbladder if you taking time to get a gauge piece to put in.
And if you put the gauze piece, it's easy for suction. And when the vision is full of blood, the vision goes down. So if you suck over the gauze, it becomes white and clear. And the third thing is, if you have a spillage from the gallbladder, the stones will get stuck in the gauze. So it's easy to take it out.
It's a very good practical point. Thank you, Dr. Sudarshan. Yes. So again, the principles, we should stay calm and inform the anesthetist team, then the pressure, and then try to identify the bleeding point. And we should not cauterize unnecessarily unless we see the bleeding point. And what do you think about, how do you advise on clipping in this situation?
Until or unless we are sure which structures it is, we never clip or never we apply any energy source. We must give a compressions. We be prepared with our all like suture, needle holder, sutures, anesthetists, everybody. Then we remove the gauze. We see from where it's coming. If we can hold it with cystic, sometimes we change the left hand with a Maryland, so you can hold better. Right hand also suction. We hold it. If we find it's like a small bleeder vessels, some aberrant vessels or something, then you can put a clip. But until unless you are sure what is there, we should not clip. Or we should not put any energy.
Okay. And if unfortunately the situation is the right hepatic artery, then what do you do? And how do you handle it?
To clip a right hepatic artery is not that big deal. If require, we can clip the right hepatic artery.
And how about the follow-up then?
It's in, by physiology, 80% of the volume of the liver gets blood from the portal vein and 20% volume from the artery. But 80% of the oxygen supplied by the artery and 20% from the portal vein. There is possibility of 8 to 10% there is possibility of liver dysfunctions. But by all considering issues, it is very transient and that goes off in over a period of time, even if we clip the right hepatic artery.
And if it is bleeding from a venous source like a portal vein, then how would you tackle the situation?
I think portal vein injuries is one of the deadliest complications during lap chole. It should not happen in any surgeon's life. If at all it happens, we should not be hesitant to put a gauze, then immediately to open up and give a compression with mops. Then if we are very confident to do vascular repair, then we do it. or else we should seek help. We should ask for some vascular surgeons to come in and to repair that. Till then, we should. But if the institute is bigger one, the situations, no, in which place we are doing, that is very important. If it is a place where really I am the alone surgeon assisting with the juniors, it cannot. So, and even sometimes the suture 5-0 Proline is not available. So at least in every theater, you must have 5-0 Proline to 3 to 4 numbers. We should keep it, just to keep it in the, for any situations to overcome. If that situation, nobody is there, you should open it, be calm, then gently, if we have a vascular clamps, we gently at least we can put a Pringle maneuver, compress, we see where we have injured, and then we can put some vascular clamps and gently we can repair. I think calmness is important for this.
I have an experience of my own with a portal vein injury. I did a lap cholecystectomy, and then the white cystic duct, I put a extracorporeal Rhodas knot, and the knot pusher slipped and injured the portal vein. And then I put a gauge piece, and with a Maryland, I just did the Pringle partly towards the diagonal side, pressing from the left hand, and then I opened. Then identifying it, I put a Satinsky and then repaired with a 4-0 Proline. But that was a deadly experience. It's very easy to say now.
And sometimes the middle hepatic vein or the branches of the middle hepatic veins are very superficial in the gallbladder fossa. So when we are dissecting and we have done the callous triangle, then we are happy and we have taken off main things. And then sometimes we quickly want to finish it, then sometimes we can damage the middle hepatic vein. So how do you handle the bleeding from middle hepatic vein?
These we say as a crash landing. So at the time of landing, means you are very happy, cystic artery duct dissected, most of the gallbladder is already lifted off from the liver bed, and at the bottom where we are at the superior part, when you're dissecting, you just leave your plane and go inside the liver. And we thought it's a sinus. Basically, it's not a sinus. It is the starting point of the right hepatic vein. And basically, that point, there is a gush of blood. Immediately, the gauge piece or the liver, gallbladder, whatever happened, we compress. Ask the anesthetist go for hypotensive, slightly hypotensive anesthesia. We be prepared. Until and unless we put a suture, we cannot manage this bleeding. Always you should we can try some energy source that will increase. We put some gel foam packing that will not hold. It is only suture. And this situation, the suture, what we follow now, that is not available, mostly the catgut, 2-0 catgut is a better to put because the catgut swell up. After putting in the suture, it swell up. Or else we can put some monocryl 2-0 monocryl sutures. Gently we can suture. Only suture can help.
So only suturing, no.
And better to put the patient in a supine position to avoid air embolism.
No, that's
rather
right.
than
We'll
keeping the head up.
Give a compression.
So the bile duct injury is the disastrous complication that can happen. So the incidence is about 0.2 to 0.4% in laparoscopic cholecystectomies. And the presentation could be, if we are lucky enough, then we should be able to identify during the surgery, which is the case in about 1/3 of the cases. And we are not lucky in about 2/3 of the cases. And Dr. Sudarshan, when do you suspect, when you should suspect bile duct injury in a patient?
Always. Each and every case, you need to think whether have I damaged the bile duct or any injury to the bile duct has taken place. They say most of the time the bile duct injuries have taken place when the surgeon thought it's an easy piece. Majority of the injuries have taken place when they thought it's an easy gallbladder. So always we have to have a suspicious mind to make sure whether there is an injury. Of course, if there is an injury, identifying it during the operation will have better outcome for the patient. And when it comes to the post-op patients, any patient who is not doing well after a laparoscopic cholecystectomy, we should always suspect in that case. If the patient just can't walk to the washroom, there should be some doubt about it. Undue pain on the next day. And the trainees, it's important, biliary peritonitis is not a very strong peritonitis on the first day. Not like a gastric perforation or a pus in the peritoneum. The biliary peritonitis shows very minimal signs on the first day. So we have to think about some patient is not doing well, patient become hypertensive, patient has fever, patient has, on the face you can pick it up, there's something wrong happening.
Can I give one? You have told that there is a possibility of bile duct injury in cholecystectomy is 0.2 to 0.4%. Basically, these statistics is for the surgeon. If I do 100 surgery, I have a 0.2 to 0.4% bile duct injury. But for the patient, it is 100%. For a single patient who have a bile duct injury, for him or her, it is 100%. So bile duct injury is one of the most dreadful complications in lap cholecystectomy. And during surgery, if we have ever seen any golden yellow bile, we must be suspicious that there is something wrong. Something wrong. It's not a gallbladder bile, it is bile from other source.
Okay. Thank you very much. So there are several classifications of the bile duct injuries, the Bismuth classification in pre-laparoscopic era, and then the Bismuth-Strasberg classification in laparoscopic era. And then, because of the time issues, then I will just go through the slides. And then the important thing is, again, I think because we need to understand when there is a vascular injury, then we have to delineate the anatomy of the vascular injury at the same with the bile duct injury, and then only then we should proceed to the definitive procedure. And the Prabhupada, do you want to add something more to that? How should we approach a patient to a patient with bile duct injury, the initial stage and then the later on?
Yeah, I think I'll think of the Sri Lankan context. If you are working in a hospital where there is a center or periphery, I'm talking about government hospitals, not the private hospitals. Most of our trainees are almost 100% in the government hospitals, and we all have done that. So if you see golden bile and you are 100% sure that it came from your gallbladder, that's not a big deal. I think by now you should be able to understand that. But if you see golden bile where you have a doubt that something gone wrong, I think the first thing I would do is to stop the dissection there, apply a little bit of pressure. Most of the hospitals have another surgeon now. To get the other guy in and together try to make a decision. That's the first thing I would do in day-to-day practice. Which means that if you have got two surgeons in the same hospital, other surgeon should be your best friend also. Don't fight for beds. That's a very important point. Huh? Otherwise it's a problem. I'm just telling you because I've seen this from ministry times. There are two people, best friends in the theatre. Anesthetist should be our best friend. She or he might be a terrible anesthetist, but he should be our best friend.
Very rarely.
and the nurse. Never fight with anesthetist and the nurse. If you want to be a successful surgeon, you are going to get into trouble, especially if you develop a complication. Because nowadays, unlike during our time, there is medical legal implication. These people might be asked to come to the court case also. So we have to be very, very careful. Anesthetist should be your best friend. Okay, remember this forever if you want to be a surgeon in Sri Lanka. The other thing is that if there is a doubt, you call the other surgeon and together you decide. If there is a doubt, you will ring someone in the center and discuss what's going to happen. And then accordingly you decide. Don't overdo things. Maybe with two surgeons you might open and sort it out straight away. I think outcome is good if you have got two surgeons doing it. Even if it's a bile duct transection, primary surgery not by yourself, but there will be someone else and who will take over the operation if it's a good guy. If there is a doubt about it, worst scenario, go in, tie it and send the transfer of the patient to somewhere else. But having organized the whole thing properly, that is, then there is no contamination and the surgeon in the center who's got a big team around him and get around and sort it out straight away. And that's, I'm talking about the reality in Sri Lanka, not
Bile duct injury can happen. But we should act, first of all, we should identify in power operative situation itself only that we have done bile duct injury. This is the first important issue. Second, it is always better not to be repaired that injured bile duct by the primary surgeon. It is always better to be repaired if there is any sufficient expertise available in the hospital by a second surgeon. If not available that one, it is always better to put a drain, manage the vascular injury for ductal injury, you put a drain, shift to the patient to somewhere where there is a expertise available. There is no harm, and explain the whole to the relatives of the patient that this is the situation, I am sending this. I think that can relieve all our medical legal as well the patient's life.
Actually, in bile duct injury, all younger surgeons should remember, earlier it is dealt and the first time it is dealt, it is the best outcome. So if you are not exposed, not expertise, no expert team or the amenities are there, do nothing. Put a drain and what Dr. Tomanas Choudhury said, to send to a higher center. That is the best possible give the best possible outcome for the patient, and also it will be an outcome for the surgeon because there will be no act of negligence. But rather trying and making it more difficult, the patient will be subsequently biliary crippled.
And that will also reduce the mental stress the surgeon has if he keeps the patient on the same place and trying to treat the patient himself. And the other thing is, I learned this from India a couple of years ago. They used to say, there are two groups of surgeons. One group, they have already cut the bile duct. The other group is waiting to cut it. So there is nothing to feel bad about it. Just call somebody else in.
I think I just want to add this because in the College of Surgeons induction also I said this. The point is this, before surgery, have a nice chat with the patients and the relatives. There are different levels of patients you have, right? And explain everything beforehand, including the bile duct injury story. So that it's easy in case of unlikely event of getting into trouble, you have got into a level playing field before, because you have discussed that before. You don't give a 100%.
Consent is also very important. Consent is also very important in the court of law. So consent should be written with all the possible complications that you have explained. Whether you have not or not, that is a different thing, but the paper will talk in the court. So this is very important.
Patients will never put you into trouble. Patient is in the same wavelength with you before surgery. Problem is you are there and he's there and something goes wrong and you go there and he'll go there.
I have seen some surgeons say they did the bile duct injury and explained that it is a Miriji syndrome. Because of Miriji syndrome, duct got injured. But I think there is no way of away from the problem itself. You cannot prove it's a Miriji syndrome by previous USG, MRCP, all these.
Yes.
We should face the truth and with your all honesty and ethical manner. That is always better.
You can't explain Mirisi syndrome to a patient after bile duct injury. It's not going to work. You can tell it beforehand.
And the surgeons community is very rarely friend. We must remember that. When I say to my students that when you are in trouble, your shadow will also leave you. You should be alone, and only the file will save you or will put you down.
Okay, then moving on to the principles of management. So we conclude because we have discussed most of the things. The control of sepsis, then we have to delineate the anatomy of the bile duct or the vascular injury, and then we have to re-establish the biliary continuity. So this concludes the presentation, and thank you very much, Professor Mohan Silla, Dr. Tomanas Choudhury, and Dr. Vasu, and Dr. V. Sudarshan for answering all the questions. And do you have any questions, audience?
Any mic, please?
you use the port dilator or you just enlarge the port and take it out?
What we do, we always put in a bag, that I told you. So we take out the bag, some part, and we cannot take out the stone. So always we put some dilatation of the port itself with a hemostatic forceps. That is sufficient, it's okay. Otherwise, we put a forceps within the gallbladder. We cut the gallbladder, we suck out the all content. Then the bigger stones we try to hold with a forceps and try to rotate and come out. If it's not sufficient, slightly we increase the incision and we take out in that manner. Or if required, we break within the gallbladder, within the bag, then we take out.
Can I just add something? I actually learned this technique from Dr. Sanjeev. He was here. I think he was here before. Now, when the stone is bigger than the port opening in the I normally do it to the epigastric. Some people do it umbilical. This is my practice epigastric. You feel as if you want to dilate it. Now, one thing you should not use to dilate is your strong scissor. Straight strong scissor, if you dilate it, you without realizing, you cut the bag off. When you try to pull it out, there is a line of the bag cut. Best thing would be to have a strong, straight artery forceps, blunt end, and do it and getting it. And under direct vision, stretch it. Nothing will happen. You can actually really go to good stretch, but make sure that you get a lot of local after that, because the patient is going to complain now.
Local anesthetics and close the port properly. Otherwise, there is chance of hernia.
But epigastric, you don't get a hernia, unlike because it's very high.
Yes, sir.
Thank you very much for that very enlightening discussion. I have experienced not as much as you have, maybe about 750 lab colleagues in my career. One of the most difficult things was when to decide after an acute attack of cholecystectomy when to go in. Because most of our patients come to us sometimes beyond the golden hour, like Professor Mohan Silva said. So I have found out when we send the patient and ask them to keep for long durations like 6 to 8 weeks, they get recurrent attacks. So then they get more and more recurrent attacks. And when the gallbladder again comes there, it is fairly more than fibrinous adhesions, you get fibrous adhesions. So dissection is fairly difficult in that case. So I don't know, my personal experience is I generally go in after about 2 to 3 weeks, where the adhesions are fibrinous and easily broken. I don't know what your ideas about this.
In a late phase, it is not the inflammation which is worrying. It is the edematous spot which is more worrying, the gallbladder wall thickness. So you should have a mindset that I may better avoid the callots dissection if it is difficult. Because of the edema, you might injure. So you should have a thought process of going for a subtotal. Because I have reservation regarding the top-down method. In a particularly chronic cholecystitis because of the short contracted cystic plate. So the carina is also pulled up. So coming down becomes more difficult. And recently, in the recent Bloomgard also, the latest edition, there are 4 European and American associations are also in the same line that top-down method should be avoided until the infundibulum is 360-degree dissected.
In practical terms, your answer to your question is, the way I saw this, patient comes from the time of the onset of pain, 10 days, you know it's not going to be easy inside. What I would do is, I will sit and explain the whole story to the patient and let the patient decide. I can remove the obstruction, I can remove your gallbladder, I can remove the stone, but chance of doing this in laparoscopy is there. However, safety is number one. In that case, chance of opening is high. In which case, I may not remove the entire gallbladder. Nothing is going to happen to you as a result of it. I'll remove the stone, but rest of the gallbladder will contract. Or else you wait for 6 weeks, but during that 6 weeks, there is a 20% chance that you get the attack again. However, if that patient takes a 6 weeks area and came back next week with a severe attack, Patient has understood and patient will tell you, doctor, it doesn't matter, you get on and do it, open or anything, I don't want to get on. Then you are in the same plate.
I have one question to the panel. Say that you have gone in and you find the environment very hostile and you start a little bit of retrograde dissection and suddenly find out that there is a huge stone stuck at the neck of the gallbladder and possibility of a cholecystoduodenal fistula. What are your thoughts on that?
If any stone stuck off in the snake of the gallbladder, we always operate. And if require, even it's a very nearby, like a, what I say, Merigi over CBD, then we open the gallbladder, take out the stone, we see how much infundibulum is rest, then either we can suture and we can take out. Means stuck off stone in the neck of the gallbladder, never the symptoms will go on. It will increase.
My question is, will you do anything for the fistula or just leave it and close the
if there is a
gallbladder?
fistula,
Yeah, that's my question.
I have seen surgeons joking about, surgeons say they injured the duodenum at the time of dissection, I'd say it's a cholecystoduodenal fistula. We should not. So if there is a duodenal fistula, we should repair it. Until unless we repair the fistula, there is nothing helps. We should put like a perforation, peritonitis of a duodenal D1 perforation, same way we should suture the duodenum. We should cover it with omental patch. We should, always. And if any suspicion, sometimes it happens, thick fibrous tissue with gallbladder and duodenum, we are not very sure it's a fistula is opening or not. We should put amount of fluids and we check any bubbles is coming or anything wrong is coming, then only we leave it. We must be very sure there is not a single fistula of duodenum should left out.
Yeah,
My question actually is, say that you have come up to that point and you realize that there is a possibility of a cholecystoduodenal fistula and the medial environment is so hostile that you can't, say one from check out what the structures are.
Now,
in that case,
we try to dissect by energy, by suction, and by cold knife, cold scissor. In these particular area where you have suspicions of duodenal fistula, you always a scissor. No energy, no suction, forceful suctions, but with a scissor. If gallbladder unit open, no problem. At least duodenum should be saved. In that way, closer to the gallbladder we dissect. If we are sure we can dissect between the duodenum and gallbladder, only then we can complete the cholecystectomy.
Can I just say, this is tiger territory. This is inflamed tissue. Open the Hartmann's pouch, remove the stone, just close the thing and come out. That is, I would never open a very inflamed tissue and trying to repair a cholecystoduodenal fistula, because if the duodenum starts leaking, all of us agree duodenal leak in an inflamed tissue is a disaster. Duodenum is a very poor tissue structure to heal. So if there is a worry, just retract, get out of it, because it will contract anyway. Once you close the Hartmann's pouch, leave a bit of gallbladder, nothing is going to happen to that. Yeah. Inflamed tissue, you have to be very careful.
One question.
Yeah. Yes. Mike, give the mic.
So I think there is quite a difference in opinion between two of you. I think my message to fellows who leave my department after a 3-year training is answer 3 questions. Who are you? Where are you? And who is the patient? Who are you means, are you Mohan De Silva who's got extensive training, HPB surgery, or are you a novice? Where are you? Are you in a central, like in our hospital, if you have difficulty, we do an intra-op ERCP. We put a stent and then do a subtotal cholecystectomy. There's no difficulty. If I have a cholecystoduodenal fistula, I'll always dissect the fistula and close the duodenum, put methylene blue to check there's no leak and get away with it. The third answer is, who's the patient? Is he a grade 3 ASA, 80-year-old man with IHD, 20% EF? Where I agree with you, bail-out procedure. So if you can answer these 3 questions, who are you, where are you, and who's the patient, most times you'll be safe.
Fine. That's it.
Actually, I want to know, we regarding putting a drain, usually we put a drain, obviously when there is an infections and bit of bleeding. But do you put a drain as a routine, or if there is a suspicious of any kind of bile injury to detect it early?
Earlier we put routine drains, but at least the last 7-8 years we are not putting routine drains. Only if we have at the time of dissections, if there is some inflamed, there is some bile, pus come out, gallbladder opened up, there is some stones spillage, we take out some suctions, irrigations, we have done a lot of irrigations. On that situations we put a drain. And we have any suspicions, like as we did a subtotal cholecystectomy, there's a very friable stump, we suture, we always put a drain. And those, if we put a drain, it's always better either put a 18 to 20 French drain and a good enough drain, not like only a small ryle tube and come out.
In my mind, open, laparoscopy to open, I suture, stump is unhealthy in my mind at the time of surgery, that is a patient I will put a drain, not otherwise.
And if, during surgery, if there is a bleeding from liver bed, we have suture it. We know that bleeding is stopped, everything controlled, we put a drain. On those situations, we put a drain. Anything very inadvertent at the time of dissection and surgery, we put a drain. But in true sense, drain never helps. Huh? Huh? We'll wait and watch. If the patient is stable, no hemodynamic situation, no abdominal signs, if the only bile is draining to the drain, we'll wait and watch.
That is called the phase of denial.
And at the same time, we should counsel with the patient that patient may need an ERCP or stenting.
No.
At least this much we should explain.
Normally, we discharge the
24
patient
hours.
within 24 hours. Even next day morning, we discharge. We will not discharge this patient. We will keep this patient for some more long time. And we observe how patient is behaving, abdominal conditions, patient hemodynamically, everything. We check LFT, we check patient. So if we monitor the patient properly, if nothing happens, even this situation, we can wait for at least 7 days and we do put a ERCP stenting if that continues.
I'll tell you something. Next day morning, when you go for the ward down, patient should be reading a newspaper. If the patient is not reading a newspaper and lying down and crying and grumbling, something wrong, send that patient for an ultrasound scan. If there is a subhepatic collection, there is a bile duct injury until proved otherwise, and you will have to take, there is no more phase of denial. Because the longer you wait, there is infection there, and it's going to be big trouble. That is my personal experience.
All
I've seen enough of it.
investigations we do, USG, LFT, all we do, we monitor the patients in a utmost care. It is not that within 24 hours if bile is coming, we should aggressively go for ERCP stenting. That is basically, at least if basically MRCP in these situations, at least 3 days time we give. Patient should stable, patient should, if patient not behaving any wrong, we will not hurry. That should be the, that is what we follow. We will not hurry by seeing only bile. We should not be panicked.
So I have got two questions in relation to symptomatic gallstone disease patient presenting with paramyelic. Patients usually presents with symptomatic gallstone disease and a fairly large paramyelical hernia. If they request both surgeries together, in the sense that Lapoli plus mesh repair, what would be an answer?
Parthasarathi will do both laparoscopically, but we never do. We do Lapcole and paramyelical hernia open mesplasty. But I know Parthasarathi, they...
It's like the same though?
Yeah.
No, you can go in a different plane.
There is enough
Intraoperative, and you
complications.
can come extraperitoneal approach or ribstopa.
No.
You can think
There
of.
is intraperitoneal mace placement. There is enough.
Yeah, there are. How much, what is the condition of the gallbladder and how the peroperative prospect? Because
But
if it is an
truly I am
addition, then
in our center never we do. We never do.
Yeah, in elective
Together.
cases when
In
the
open hernia repair and laparoscopic cholecystectomy.
in elective cases when the gallbladder is not inflamed and the markers are okay, then I have seen and done both operations at the same time laparoscopically, no harm. But when the gallbladder is inflamed and patient has come with acute presentation, then it's not very good to have a mesh in that place.
Just to add to what Sudarshan said, if the gallbladder is inflamed, you can actually repair the hernia. There is no problem. You can go through the hernia, do the port your camera through the hernia and do that. But if the gallbladder is inflamed, or even if the gallbladder is not inflamed, I am little bit wary of putting a mesh there. I have had one experience. I really regretted putting a mesh. Without even an inflamed gallbladder, maybe the instruments, remember that our camera is not 100% sterile, right? So all you need is a couple of germs in a mesh, getting into trouble. I would then do a conventional hernia repair. There is no problem. But you explain that to the patient.
The other question is that when a patient comes with symptomatic gallstone disease and the patient had a previous surgery there with a fairly big mesh around the umbilicus, so what would be your advice for placement of ports?
Our access point, as we do in Veris, it's a Palmer's point, and even sometimes by heroic, we put the Veris in the right subcostal, 5 millimeter trocar, either in Palmer's or right subcostal. We put the 5 millimeter trocar, we go in, then we check how much. Truly, even if it's a biological maze, intraperitoneal, most of the time they have adhesions, some amount of adhesions. May not be like huge, but there is some amount of adhesions. And we check it. If required, we can put the lateral ports, we dissect, come down the dissection, then we put the visual port, supraumbilical or infraumbilical, then we do the procedures.
In such case, we have to understand that what was the hernia position, whether it is umbilical or something else. Accordingly, that part should be avoided, and preferably a 5 mm port is a better option than a 10 mm port.
Yeah, and the ports become off axis at that time. The operation may be little more difficult than expected, and you must be waiting for it.
So regarding your first question, our institute is the one first started the clean contaminated case, mesh in a clean contaminated case. And we started doing many cases, as you told, it's come with the hernia, small hernia. And then initially we thought, okay, we do lap chole with the anatomical repair of hernia. Then we realized that it is very clean. And then what we do, we change of trocar and instruments for a hernia surgery. And then we didn't, that initially we keep the patient for, with the IV antibiotic for 3 to 4 days, but no infection. Then we slowly change the pattern. So we are not giving any extra antibiotic. So it is a clean contaminated case, is very well acceptable. And we combined with the sleeve gastrectomy, TLH, total lap hysterectomy, and many other procedures. And now suppose if we feel that patient had acute cholecystitis and they want to repair the hernia at the same time, now we had an option that it is a biosynthetic mesh is available. That is one company called Phase 6 from a BOD company. So that mesh is a biosynthetic mesh, and it is for a contaminated field. You can keep, even in the fecal matter is a perforated sigmoid or something, you can repair and then you can keep the mesh. So that is cost is more, and it is very lot of paper, is more than 100 articles now. It's supportive that it is a biosynthetic mesh can keep in a contaminated field. But we have enough article from GEM, almost 6 article we have that says that it is a lap chole is combined with the, any of the hernia procedure. And that is one thing. Second point, sir, with the permission from the chair, that drainage in post-lap, after lap chole, and for beginners, suppose you are separating the gallbladder, it must be simple gallbladder, you are separating it, if you are puncture the gallbladder. So what happened, the entire liver bed become a bile stain, and then that kind of cases, it's better to keep a drain for 1 day. So what happened in one of my PGs, he did a lap chole, and then my unit policy is all postgraduate student, we have to keep a drain, lap chole means. And then we could see the bile from the bag. And then immediately, within 3-4 hours time, then again we did laparoscopy, we could see the accessory duct. That is one of the very rare condition. And what happened, even the post-operative ERCP will not helpful for stop the bile. So it's better if you puncture the gallbladder when you are gallbladder removal, then keep it drained for 1 day, they can remove it. Thank you.
Regarding the concomitant surgery, like hernia surgery along with the lap chole, I want to take you to a different scenario. Like suppose when you are doing a hernia surgery and you make an enterotomy. The previous teaching was that you should not proceed with the mesh repair and then do it on a separate sitting. But then if it is a clean wound, this thing like enterotomy, so you can close the wound and you can carry on with the mesh repair. Similarly, now ileostomy closure and this thing, some people now primary keep the mesh and they do it. We are actually scared about it, but then reported rates of the mesh infection is very, very low. So I think that when you contemplate these things, if it is a clean contaminated surgery, lap chole, it can be combined with an hernia surgery. But at the same time, as I think Dr. Tamanas says, the unit practice, surgeon practice, because we are worried about the infection. We have seen the patient's sufferings because of that. Thank you.
Thank you. Wonderful.
Right, thank you very much. I would like to thank Dr. Rasika for conducting a very useful session on laparoscopic cholecystectomy. Now I would like to invite President of SLAMADS, Professor Bhavanta Gamage, to come on stage, please. I would like the panelists, if they can stay on stage for a minute, please. Yes. We would like to thank Dr. Tamanas Chowdhury and Dr. Biswarab Basu for coming here, and we have a small token of appreciation. So,
Should we come front?
thank you, Dr. Tamanas. Thank you, Dr. Biswarab. Now I would like to invite Prof. Bhavanta to give the certificates to the local panelists. Professor Mohan De Silva. And Dr. V. Sudarshan. So we'll break for tea. Because we are running behind time, we'll quickly gather back for the colorectal session. So I would say we'll reconvene in about 10 to 15 minutes. All right, thank you.
Nice model.
Excellent moderation.
Recording stopped. Recording in progress.
Hello everybody. Welcome to the second session of the day. This is about optimizing outcomes and the new techniques in colorectal surgery. And I have the privilege of introduction the panel today. So starting with Dr. Ovi Sudhir.